My name is Fedon Kaloterakis. If it is Greek to you, it's because I'm Greek. So I'm the Managing Director of the World Federation of Therapeutic Communities and the President of the European Federation of Therapeutic Communities, among other things. Okay. Before I introduce the two speakers, we have only two speakers. I would like to say that this is an event organized by the World Federation of Therapeutic Communities, but there are 5 regional federations who are co-organizers. So it's the Treatment Communities of America, the Australasian Therapeutic Community Association, the Federation of Therapeutic Communities in Asia, FLACT is the Latin American Therapeutic Communities Association, and then the European Federation of Therapeutic Communities. So it's a joint effort, so to speak. Now these gentlemen, they're both psychologists, but they're also very good friends. So our first speaker is Mr. Ed Carlson. Ed is the director of UNODC House in New Orleans, in Louisiana. An amazing program. I had the privilege to visit there a month ago or 2 months ago.
Yes, a month ago.
Amazing program. Ed is also the president of TCA, of the Treatment Communities of America. He is the second vice president of the World Federation of Therapeutic Communities and the chair of the Communications Committee of WFTC.
Correct. That's good. Not bad.
Okay, the floor is yours.
Thank you, sir. Hi, everybody. Welcome. As he said, my name is Ed Carlson. My regular job, besides when I'm not doing advocacy work, is I'm CEO of UNODC House. We're the largest addiction treatment provider in the state of Louisiana. Australia, there's UNODC houses in Australia. There's also UNODC houses in New Zealand. We all grew out of UNODC House, New York, so we're all over the place. So we're kind of connected, loosely affiliated. We grew out of the therapeutic community model. We used to be a very old school TC providing therapeutic community services to primarily drug addicts at that time. The organization I run, we just celebrated our 50th anniversary. And over the last 50 years, we've actually changed quite a bit. So since I've been the CEO, I've been there for 18 years, we've grown from just a small therapeutic community to an organization that does a lot of different things. We provide everything from harm reduction, prevention services, intervention services. We do medically supported detox. We do short-term 28-day inpatient program. We do long-term therapeutic community model of services. And we even combine with housing, job readiness, job placement. We treat about 25,000 people a year on average. We have programs throughout South Louisiana. I've been very much involved in advocacy work. Pretty much my whole career. I've been working in the field for about 38 years. I know I don't look that old. But I've been very active in advocating for treatment and treatment services for all kinds of different modalities. And in part of our advocacy work, we do a lot of data collection. We gather information. We've been looking at ways to sort of get information out to people about the work that we do, the impact that we have overall. Just as an example, UNODC House, we did an economic impact study for the state of Louisiana. We had an outside group come out to review, and at the time our budget was about $11 million a year, and it was able to show the state of Louisiana that $11 million investment saved the state of Louisiana $79 million a year. So when you're talking to policymakers, and people, you say something like that, they're like, what? You say we saved how much money by investing in your program? And then they're like, well, why don't we invest more? And I go, that's a good question, why? And so we're constantly looking at ways to sort of gather information. And so as chair of the communication committee, I've been able to work with a whole group of people, Pablo being one of them, who will be he's an amazing data gatherer, putting things together, and organizing it and crunching the numbers and writing reports. I am much more, as you can tell, sort of the sales guy on how we're going to go ahead and sell and look at this information and data. But I find that this is very important. And so what we decided to do was looking at our members from around the world, and each year we're gathering more and more information on other programs and stuff. And it's also really interesting because we do a lot of work with HIV, almost all of us across the board. Obviously, the addiction community is very much dealing with HIV and HIV issues related to it. So we're looking at different ways. So this is our second report. we thought it would be a great thing to share. We have a third report going to happen here in a minute. I'm going to talk a little bit about that a little later. And I am going to turn it over to you, sir. Do you want to introduce it?
Yes. I mean, you almost did it, but okay.
Sorry.
I feel useless. I mean, you can just do it by yourself.
No,
That's okay.
No.
Dr. Pablo Kurlander, well, as I said, they're both psychologists. Pablo has a PhD in public health. He's the director of the Eureka Educando Institute. Yes.
Yeah.
And also the coordinator of the postgraduate program in addictions of the Inspirar faculty in Curitiba, the city of Curitiba in Brazil. Although he's from Uruguay, he lives in Brazil for almost 30 years.
30 years.
Yes. He's a member of the Communications Committee of the World Federation of Therapeutic Communities. He's a former vice president of FLAC, the Latin American Federation of Therapeutic Communities, and the former general coordinator of the BRACT, which is the Brazilian Federation of Therapeutic Communities. And this was an endeavor that started actually by the Italians, Enrico Costa, the first vice president of the WFTC, had this vision of doing this report, this world report. But Pablo now is a coordinator, and I think he's the soul of the whole thing.
And he's wicked smart, so he knows how to take this data and information and make it have it all make sense.
The floor is yours, Pablo.
There you go, sir.
Okay, thank you very much for introducing me. I'm really glad to be here with all of you and to be part of this endeavor. It's a really great thing to could show the impact of the therapeutic communities in the world. I'm from therapeutic community for 30 years. Like many people who work in the field, I was treated in therapeutic community. I went to Brazil to start this process, like many people who work in this field today. And for me, it's really a passionate thing to talk about something that really worked for me and really worked for many people I know, many people I treat, and many people also need to be treated now and in the future. So we can start reviewing the first 2 years, the first 2 reports we have. So at the beginning, let me draw your attention to the total number of respondent organizations we have. We moved from 134 to almost 400 organizations, which means a significant growth of around 300% in the total number of organizations. Of course, we had more.
These are the organizations who responded.
Yes. Not the total organizations we have in WFTC, but we are trying year by year to increase engagement of all the organizations in this endeavor, because it's really hard to collect data, and we know without data nothing happens. But in the field it's happening, but we can show what's happening, what's actually happening. In the total countries, the participant organization countries, we can see a same pattern of growth, moving from 26 to 40 countries, an increase for 150%. And in the second report, we were present in all the 6 regions, because in the first report, Africa was not represented, and in this 2023 report, Africa was there. Of course, we are working to engage more African organizations in this new report, this year report, but of course, this is the beginning of something that will be bigger and bigger. A quick glance in the number of assisted and reached people, we can see the impressive number of almost 2 million people with the regional distribution here in the pie chart on the right. We can see that Europe, Latin America, and North America were the most representative regions in assisted and reached people. When we talk about assisted people, is the people directly treated in TCs, and the reached people is the people who was touched with other kinds of work like street outreach, prevention programs, family programs, educational activities, so all these kind of other people who is touched and reached by the TCs. Commonly, people that are not of the field think that TCs only reach the assisted people, the people who is in the TC. But for each people who is in the TCs touch a lot of other people. So there are a lot of people directly and indirectly touched or reached by these programs. So this is really interesting. And comparing with the last survey, we had an increase of 300%, moving from 500,000 to almost 2 million. And as I said at the beginning, of course, this is not the total number. This is the number we could gather in the second survey, but we could, in this third survey, gather a lot of more organizations and more data to show more expressive results. We choose these three variables: scope of work, type of work, and number of employees, to analyze the organization size. As we can see, the national, local, international, what the scope of work, more grassroots in the type of work, and less than 10 and 10 to 50 numbers of employees. We can see that most of the TCs were small and medium-sized. So especially in less developed regions, the TCs are small TCs. So as we can see in the next slide, this is one of the main challenges of the TCs, to could support their works being small organizations. For example, about the source of funding. Regarding the source of funding, we asked the TCs to let us know which of these 7 sources of funding they had access to. We can see that most of the TC reported public funding, local, federal. This is something good in some regions, but in regions like my region, Latin America, depending on public funding is a really difficult issue, because the public funding in these less developed regions is so instable. So it's not, you cannot, it's not so reliable to believe in that every year you can count on this kind of funding. So another that is important, another data, is the number of sources of funding the TCs had. So we can see in this pie chart the majority of the TCs had access to no more than 3 sources of funding. So this is really unfortunate, because it's clear, we know that the less sources of funding the TC has, the less secure is its work. So depending on only 1 or 2 sources of funding is really difficult, especially when these sources of funding are not so stable. Okay? We asked the TCs too about the target population they care. We asked to identify which of these 10 target population they care to, and the most represented was adults. The other kind of populations are underrepresented, especially the children, that are a population that year by year need more and more care. They are this is not the total number of TCs, but we know that this is really representative of the distribution of TCs in the world. So we really need to broaden the impact of TCs regarding the target population. And about the number of target population, the pie chart, we can see that most of the TC reported 4 or less different target populations. The breakdown in target population gender is as follows. Most of the TCs, or half of the TC reported having female and male separate facilities. The other half only male. And there are few organization that had only female facilities. We don't have the number in this 52% of how much of there are female and male, because they reported that they had both, but in this survey we don't know how much of each other, how beds, or how the number specifically in male and female. In further survey we could see this number, and even though these were the half, the female and male separate facilities, most of the assisted people were in this kind of organization, which had both female and separate facilities, as we can see in the graph at the left. Regarding the settings, we asked the TCs about which of these 4 different settings they had: residential treatment TCs, ambulatory treatment TCs, another kind of ambulatory treatment, the harm reduction facilities, and housing facilities. At the beginning of the TC movement, most of the TC, or all the TCs, were only the residential treatment, and some of them ambulatory. But now we can see that even most of the TCs were reported having residential treatment. It is important to highlight something like the almost a quarter of the TCs, 22.9%, reported having harm reduction facilities. This data shows that global TC services are evolving to be a person-centered and adapt to their needs in a continuum care of logic. So the TCs are developing to develop other kind of treatment, other kind of care, even when many groups believe that there are different things, TC and harm reduction. But this data shows that not necessarily must be in opposite or in different size or in different approach, but could be gathered in the same care model. Regarding the number of settings, most of the TCs reported having only one setting, and 30% too. So until today, the TCs still have only one model in the most. Regarding the variable, the average proposed time for treatment, we have these 4 different times, and most of the TC have reported having programs from 6 to 12 months. At the beginning, TCs used to have longer programs, more than a year. So this data shows that TCs are evolving to what is called the modified TC, with shorter programs. We have 20% of program from 3 to 6 months, but of course in the past it would not happen. So now it's a really important data showing the developing of the model. So the TC model is dynamic, it's adapting to the new challenges, adapting to the new needs of the people, adapting to the new mainstream of the treatment models. And regarding the assisted people, most of the people were assisted in these programs from 6 to 12 months. Another important variable was the TC location. We can see that most of the TCs reported having urban facilities. This is something new too, that shows the developing of the model, because at the beginning TCs were almost all rural. So most of the TCs reported having urban locations, urban facilities is something really new, and another data which shows the developing and the developing of the model to these new challenges. About the assisted people, even though the urban facilities were the most the people were more assisted in rural TCs. Probably this means that the rural TCs have more number of beds than the urban TCs. The difference is because in urban TCs, access to the healthcare network, the staff access to the TC is better, so there are some things that are really better in urban TCs that what this mainstream is developing to have more urban TCs. The new TCs prefer to be in urban location, of course. Religiosity is a concern, of course, in the TC movement. We know that originally at the beginning, most of these programs of the movement were related or were improved by religious movements. We asked the TCs about these three kinds of programs: non-religious program, religious with non-mandatory religious activities, and religious with mandatory religious activities. And we can see that most of the TCs reported having non-religious program. And it's important to highlight that WFTC doesn't agree with mandatory religious activities. We asked them to know, but there's something that is not the mainstream was not the right way to work in TC model. The concern regarding this question of religiosity is the wrong use of religiosity and spirituality. It's not about being good or not the religious activities, but in many times the wrong use of this kind of activity could resemble religious proselytism and could incur in violence and violation of human rights. That's why this is a real concern of us about the best practices and the evidence-based practices. The people were most assisted in the non-religious programs. So even having TCs which report their mandatory religious activities, even almost the total of the people were assisted in the non-religious programs, which is something to highlight too, because in many times and many groups think that TCs are only religious groups, only religious-based treatment, and this data show that it's not true, or it's not true anymore. The last variable was the staff. In order to simplify the filling of the form, because it's really hard to fill the form, especially for the small TCs that don't have so many staff, we didn't ask how many of each professional of these each TC had. So here they only had to select if they had or not the professional. As we can see in this graph, the more present professionals were the psychologists, administrative, financial, counselor, and most of them are recovery addicts, and the social workers. As we can see in the second graph, more than 80% of the TCs reported having 5 or more different professionals in the staff. That is another that important to highlight, because the people and the groups until today think that TCs are not professional-based treatment. And this data show that there's a lot of professional TCs, and especially when we think about the total assisted people. We can see here in this graph that the most of the people were assisted in TCs, which reported having 8 different professionals in the staff. So, as we can see in the whole data, most of the people were treated in professional TCs, in non-religious TCs, in TCs that have different facilities. So what we can see and what we want to share with the global movement is that TCs are evolving, are developing their programs, and they are not what most groups until today think about the TCs. So we can show the great impact, and of course we need to develop a lot, we need to continue developing. We are not in the ideal kind of work because it's impossible to reach it, but this data shows the need to continue developing, but we are in the correct way, of course.
Can I say something?
Okay.
This also shows that most teams are multidisciplinary teams.
Yes,
Yes. It has to do with the tradition, but it's also an evolution of the TCs, that most teams are professionals but multidisciplinary teams at the same time. Sorry.
Okay, finished.
But if,
No, that's it.
Yes.
and to add what Fabian was saying, I think that we're always constantly looking for outcomes. Like, what are the things that work? And so we're starting to find more and more integrated models really help with maintaining and keeping with long-term sobriety, and also meeting the client where they're at. So, like, for example, a lot of programs sometimes will have multi-levels of programs, like my program has. You know, some people only need maybe detox in a 28-day program. Other people need 7 to 8 months of rehabilitation. And really kind of meeting the client where they are and where they need and what's going to work best for them. But also combining primary care, mental health, and substance abuse counseling, you know, in an integrated fashion actually improves the overall outcomes. And I think regardless of where we were around the world in our surveys, people were realizing that we need a lot of different things based on what the needs are for the client. And so it shows, I would say 25 years ago, this would not have looked like this. I think it would have looked kind of just more like paraprofessionals and not really as much clinical staff associated with it. But it has definitely been changing and evolving over the years.
And also, as far as outcomes, it is obvious because, you know, we have the research now, we have the evidence that the longer the program, the longer the duration, the better the outcome.
Yeah.
So, because of financial reasons and economical reasons, programs become shorter and shorter, you know. But research shows that the longer the program, the better chances for avoiding relapse. But I think that was your presentation, correct?
Yes.
Do you have something?
That's
Yeah,
right.
yeah.
Do you want
no,
to add
no,
anything else? Was that the end?
Yes. And
After you-
about
Go
regarding this issue of the time, I forgot to talk about this a specific issue because there's a controversy in this because the longer the program, the better outcomes regarding relapse. But on the other hand, the longer the program, the less adherence and more dropout too. So this is one of the conundrums we have in our field because we need to consider the funding programs, which needs shorter programs. We need better adherence, so longer programs could mean less adherence. But on the other hand, shorter programs could be less effective. So, of course, there's something to what TCs are doing. The better TCs and the movement is doing is to have, as we could see in the presentation, different kinds of treatment facilities. So the treatment could be longer, but not all the treatment must be done in the TC. So if the client or the patient could develop in different programs, starting in the residential programs and continuing in the ambulatory program, this concern about the adherence and dropout could be solved because the problem of adherence is especially in residential treatment. So this data shows that many TCs have both programs. So this is really interesting because of this. We could talk about better results about the relapse, and we can talk about better results about regarding the adherence, merging these both approaches. Okay.
Yeah. No, but I think we should thank you first before we go on. Not only for the presentation, but this is a massive piece of work. I mean, it's a lot of work. So thank you very much. This is a time, we have time for discussion, questions, comments. I saw him.
Just have a quick question: is how and when can we engage to this survey? So if I am a therapeutic community or I'm running therapeutic communities, is there any website or when? What is the time for submitting data? And
it's funny you should mention that. We are actually launching today to start our third report. So anybody who is interested in contributing, or if you know of treatment programs who are interested in contributing, you can go to our WFTC website. So, and there is a form that you can fill out there, and we're very interested in getting as many people and many groups as possible involved, and it's easy for people to be able to access that. So we're starting to send out, looking for surveys, and we'll spend like 4 or 5 months reaching out to programs around the world as we're looking at that. So we have our online survey. The goal is to we're trying to get it completed by June 14th. And there's also a newsletter you can sign up for. We do a weekly newsletter on things that are happening around the world in relation to treatment and addiction. It doesn't cost anything. You just can sign up through there.
Yes, please.
Hello. I have some questions. I have some questions. I have more than one. But
we have some answers.
the first question, Pablo, you mentioned this perception of TCSs. What do you think is the general perception of TCs? You mentioned that there is a way people see. I'm just curious to understand from you.
Yes, in the field of drug policies, there's a real polarized vision. Most of the people engaged in drug policies around the world are or for or against. It's really difficult to have neutral sides about the disease. The for is, of course, the people who is of the field and the people who needs of this kind of treatment. And against, there are many issues to be against, especially the people who is against, the groups which are against the disease are against the bad practices. And most of them don't know the good practices, the real disease, the good disease, this kind of data. So this is maybe the most difficult issue in this discussion, because the people, the groups who are which are against, mostly don't want to know which is the real TC, what is the real TC, what is the work. So they are against. When we could talk with these groups, they are against of the same things we are against, because they are against bad practices, they are against proselytism, they are against violation of human rights, and we are against this too. So we are talking about the same things. So when these groups really are able to talk with us, we could see that we are talking about the same thing. We agree in this point. So it's not about be against the TC, but it's about be against the bad practices. So that's one of the most important work of WFTC, to improve the practices, to share to the community, the communities, and also to the general people of the groups, which are the good practices, or which practices are supported and with that.
At this, I can speak about Spain. I mean, it is absolutely integrated, at least in Spain, as any other services, well funded, and there's no controversial issue in Spain. They're professionalized, modified. We have also in prison what's called in prison therapeutic communities. In prison, therapeutic communities for women with children. We've been adjusting according to the needs but maybe if you go to another country, you might find that there's a lot of diversity in the approach and the perception that maybe policymakers or black policy in that particular place might have with the people.
This leads me to my next question, and it goes well into, are there indigenous therapeutic communities in the organisation, and are they represented in the data you're capturing?
Yes.
Yes,
No. Sorry. No, I'm not the speaker. I mean.
There are other organizations.
there are, of course.
Anyone?
Indigenous groups, yes.
Yes, of course. For us, even improving a lot. Of course, we know. For example, only in Brazil, we have almost 2,000 TCs. Only in Brazil. Of course, not all of them are real TCs and are not related to the regional federation. For example, we shared this survey through the regional federations to be sure that the TCs which respond or fill the form are real TCs. So the local federations see the responses to know if these are TCs related to them or not. In Brazil, there are 300 TCs that are part of the Brazilian Federation. So we have 300, almost 400 in the total. So of course, we have a lot of more TCs related to WFTC. So this is our work, to improve or to share and to engage these other TCs to fill the form, to show their data. So year by year we want to reach this huge number, of course.
So there are TCs that focus specifically on indigenous people, yeah. And so I don't know if there are that many that are part of the survey. I know we reached out to them in the U.S. as part of Treatment Communities of America. We represent about 600 treatment programs throughout the country, and but not everybody responded. In fact, we had less people respond this time in the U.S. than we did the first time. So we're working on that. So, but
do you have any thought? Sorry, do you have any thought around why people aren't responding?
They
shared with you, like
everybody I call, they would be like, "Yeah, I'm going to do it," right? And they just forget, right? So I mean, I know. I feel like half my day is like I'm juggling chainsaws on fire, trying to get through the day, and I got to do this survey, and I don't get around to getting it done, and so. But so we're looking at ways of trying to just re-encourage. I think people get the reports, and then they're like, "Oh, I didn't fill out the survey," and so then I usually hear from them at that point too. So that we're working on engaging with people for it.
Yeah, something we are trying to with this work is to change the cultural framework of TCs, because the staff of TC, the people of TC, used to work a lot, but not register all they would do. That's why it's difficult to show and to share the results of the work. So this kind of work of making this annually report is something which will improve our cultural change in the field, to register what we are doing.
I would like to respond also. Yes, there are TCs for indigenous people in North America, Canada and US, in New Zealand and Australia, in South America. There are, but I don't know how many of them have responded to this survey. This is a subject for another survey, why people are not responding or not responding. True, but this is the work of the World Federation also. We have to really motivate people and show to them the value of having the results of such a survey. Concerning now TCs and some controversies that you mentioned, there are programs that call themselves therapeutic communities and they are not. The confusion starts from there. Or especially in Africa, there are programs who use the therapeutic community as a method, but they have not conceptualized this, so they don't call themselves a therapeutic community, although there are a therapeutic community. So for us, though, as a World Federation, there is no therapeutic community without a code of ethics.
Yeah.
Okay? And also, there is not therapeutic community that doesn't base its practices on evidence. Okay? So this should be very clear. But there is a lot of work to be done also towards that direction. I think you want to say?
No, yesterday there were a representative from a therapeutic community from Australia called the Glenn Foundation, and they are only working with the Aboriginal populations, and they filled the survey, I know, but they are very good. Glenn Foundation from Australia, working in, you know them? But only working, or basically working for Aboriginal populations.
Thank you.
We've got a few more minutes.
That's fine.
Comments or questions? Yes? Yes, please. You?
Sorry.
Yes,
You have a
yes.
question?
Yeah. So if I understand, so I don't know too much about this whole area of work, but I understand that you said this is the second of these reports. You're obviously starting the third, like you said, and so it may be premature, but you already mentioned a little bit that you're interested in measuring outcomes. So even if you haven't really done the data analysis yet, do you have any preliminary impressions that what you've seen in the survey leads you to think you could say about lessons learned and outcomes and that sort of thing? I mean, I'm not looking for like we've got an academic paper on this, but no, I'm just wondering, just having done the survey twice now, do you have any overall gestalt? My gut is telling me from having seen all this that this is what we can learn about the outcomes, and these are best practices that we should maybe think about.
Yeah, I think our biggest thing, because I think about outcomes all the time. So, and part of because because I have to answer to the people who pay me, the politicians in the U.S., and they want to know what's the impact. And so we do a lot of review, especially when people leave the program and while they're in the program, to sort of measure various different things. But there's not the good consistency across the field around what are good outcome measurements. So like I look at things like length of stay, how long people are reporting clean and sober out of the program at 30, 60, 90, 120 days. What are they employed, right? Have they been involved, engaged in any criminal activity? What are the things that they have been? And these are some of the questions that we would ask. We've actually started to put in a process of giving small gift cards to inspire people to respond to the surveys, which we sort of helps people to sort of keep in touch with us and be able to be involved. But we probably, for let's say, out of our graduates, we barely track down maybe 40% of our graduates, and that's pretty high actually compared to a lot of other groups. So we're always constantly looking at, but I think in our mind, I think that's sort of the next thing, because we want to be able to show more about our worth, but it's also internationally becomes really different questions how people track data and information. Just like something as simple as length of stay could be calculated very differently, or whether people even have databases they can pull that information from, or they're having to pull it from hand, or having to create a spreadsheet. So so the short answer is yes. The long answer is trying to figure out how.
And you have to realize that usually we use 3 criteria in order to assess what is happening. One is the relationship of the person to the substances, although TCs are for addiction, even gambling addiction or addiction to the internet, which is a substance. So that's one criteria. The other criteria is about getting involved in criminal activities, right? And also employment is, reintegration is the third one. So there is a very good volume by Springer. It's called Therapeutic Communities and the Opioid Epidemic in America. That has a lot of research there. It's a small volume. I think we have run out of time. Yes, I would like to thank Pablo and Ed. Thank you very much. But also to thank all of you.
Thank you all for coming.
Friday afternoon at the end of the
We appreciate it.
You are here honoring us. Thank you very much.
Thank you.
And have a good weekend.
Have an amazing weekend. Thank you.